Let's move on to the aminoglycoside antibiotics. So the aminoglycoside antibiotics are incorporated into the bacteria through an oxygen-dependent process. Therefore, these medications don't work that well against anaerobic bacteria. The aminoglycoside seen in the red triangle there binds to the 30S subunit of the ribosome. Now, how it works is it interferes with protein synthesis by preventing the initiation complex from forming. So that's when the bottom of the hamburger bun, the top of the hamburger bun, and the cheese, which is the mRNA, all come together. The aminoglycosides prevent that entire initiation complex from coming together. It can also cause misread errors on the messenger RNA. So the messenger RNA is now prone to making mistakes. So instead of putting in amino acid number 5, it'll put in amino acid number 11, for example. The other thing that happens as well is that it does cause some inhibition of translocation, which is another potential mechanisms that these drugs use. They are highly dependent upon concentration. So aminoglycosides are concentration-dependent antibiotics. These medications actually work better when given intermittently. So you're better off having a high peak and a trough than you are having a steady state level. This is what makes these medications unique. They are concentration killers as opposed to time killers. So we like to have an intermittent on-off exposure to these medications. As I said before, concentration-dependent killing action. They also have a very strong post-antibiotic activity, which is why we can afford to have low levels or trough levels when we give these medications. Remember that aminoglycosides are really polar, so they must be given IV or IM. They are not given orally. They're excreted through the kidney or renally. So renal function will determine the dose. So a lot of times in patients with renal failure, we'll actually do what's called peak and trough levels. So monitoring drug levels is a big issue. The other thing I want to mention is that these drugs do not cross the blood-brain barrier. They do better as large single doses than as multi-dose regimens because, like I said, we like the peak and trough. And the toxicity of these medications limits the peak concentration. So that's what limits our top level. Now, the broad-spectrum agent active across many classes of bacteria is very typical of aminoglycoside activity, whether it's gentamicin or whatever. E. coli, Haemophilus influenzae, Klebsiella, Moraxella species, Proteus species, Serratia species, Shigella species. These are all very susceptible to this class of drugs. They are almost always used in combination with the penicillin. So there's kind of like this pairing, this husband and wife kind of team that we like. So ampicillin always seems to go with gentamicin and piperacillin seems to go with tobramycin. They work very well together. Ampicillin is more broad spectrum. Gentamicin is more broad spectrum. So we use that in more of a, broad spectrum kind of situation. Pip/Tobra is used more in gram-negative disease. And the reason why these two combinations work so well is because of something called antibacterial synergy. So what's that mean? If you think about it, the ampicillin or the piperacillin, their job is to open up the cell wall. That allows the gentamicin or the tobramycin to get into the cell, and now their concentration near the ribosome is much greater. So the ampicillin knocks down the door, and the gentamicin goes in through the door and does the job. So that's why these two drugs seem to work so well together, whether they're AmpGent or Pip/Tobra. Gentamicin is the prototypical drug. Tobramycin also has activity against Pseudomonas, and it's used more in gram-negative disease. There are a whole list of those gentamicin antibiotics, and streptomycin is one of them, and it's certainly a very effective class. Now, toxicity is going to be a big concern with aminoglycosides. Autotoxicity. So a lot of people get autotoxicity. This is on exams, and it's also something important for clinical practice. You need to be aware of this and the next thing I'm going to say, which is the difference between amikacin and kanamycin. Auditory symptoms are amikacin and kanamycin. Vestibular symptoms are gentamicin and tobramycin. So although both are working on the inner ear, there's a slight difference between the two. So vestibular symptoms are gent and tobra. Auditory symptoms are amikacin and kanamycin. Other toxicity issues include nephrotoxicity. So remember that you can get acute tubular necrosis with gentamicin and tobramycin, and you can get increased toxicity with something called amphotericin B, which I'll talk about later. Other toxicity includes neuromuscular blockade. There's often a curare-like illness, and you treat it with calcium and neostigmine. Finally, there are some skin reactions, mostly with neomycin, that you have to be aware of.